Okay, this is chapter 8, and we're going to look at identifying and preventing common risk factors. We're only going to briefly discuss some of it here because we're really going to talk a lot more about this in individual chapters coming up. But we're going to look at the broader techniques for assessing and treating factors. One of the great things that's out there is what we call start-stop. I have that out on the website for you. Looking at how do we prevent functional decline, screening recommendations, the importance of that flu pneumonia vaccine. Just going to start on the signs of abuse and the reporting of the elderly. So as we look at a lot of key terms, for some of these I do have the instruments out there for you, websites available that you can go out and review, and we'll talk about some of this as we go through this chapter. So we do have the United States Preventative Services Task Force, and they've been instrumental in assisting in what we need to be doing for preventative services. It's just phenomenal. And you can go out and visit that site as well. Healthy People 2020, again, it's all about that health promotion. And what we're looking at is from a primary, secondary, and tertiary point of view. We want to do the best we can to prevent the disease from ever occurring, early detection, and then unfortunately with our elder population, we want to prevent that progressing to chronic illness. Many of the diseases that are seen have that chronic illness. So with our health screening as a secondary form of prevention, again, the U.S. Preventative Services Task Force has given the levels to what should be screened highly or insufficient, not even recommended. One of the things we look at is medications. Does that harm outweigh the benefit of the treatment? So they're wonderful at guiding us in what we should be doing. Of the two, what has come up as the major focus areas, we want to promote physical activity in that aging client. We want to promote the best nutrition. This is why we want communities that support Meals on Wheels, access to care, ability to cook food, obviously decrease in tobacco use. We want to promote health screening. We don't want these individuals coming in and they haven't seen a doctor in 20 years. We want to be able to teach injury prevention because if we can prevent that injury, we're going to keep that client at home. Preventative medications and immunizations are a big focus. All these problems we're going to be talking about much more later on. Another big focus is on caregiver support. With this aging population, it seems like the child of this aging adult, their kids go off to school and then they're left taking over for their elderly parent. So we need to be able to support those people because that is a still very active working age group. The Chronic Disease Self-Management Program came out of Stanford University, and what their goal is to get this program into communities. And when I was playing around on it, it says it's a 17-hour course and you're supposed to go a couple hours a week so you can learn in segments on your chronic disease such as COPD, CHF, because we want to improve that symptom management at home to keep those exacerbations out of the hospital. Medication regime is the biggest thing, and as people's finances are coming into play, picking and choosing medication should not have to be an option, and that's really sad. So what we're seeing more and more of, and especially with Medicare getting involved with this, is those COPD, CHF, things that we can do to prevent symptoms from exacerbating and keep them at home by following a strict medication regime, getting people maybe on Lasix earlier with symptoms, or prednisone to manage those symptoms. How can we get that health literacy, understanding the disease, that we can self-manage better, that we're not ending up in crisis? One of the biggies, again, is physical activity. it's true. If you don't move, you lose your functional decline. We want you up and moving, and like in the one unit we talked about, 30 minutes a day, at your age, and I've got those little video clips of that incredible woman. But what is really sad is that a third of adults 65 and older don't do anything physical at all. So what we want, again, is 150 minutes, 30 minutes a day, 5 days a week of some pretty vigorous workout is what we're really suggesting. The science shows that you will live longer, improves coronary artery disease, which is the leading cause of death, increased insulin utilization in the body and blood glucose levels so that we have less complications of our diabetes. We know that exercise will help with hypertension, depression, obesity, all those issues that they need to get up and moving no matter what age. We really are seeing a lot more nutritional problems with the elderly. Lower body mass index all the way to obesity. Even with the obesity, we're seeing poor albumin levels. Albumin is responsible for holding fluids in the vascular space, so the lower the albumin, the higher chances of edema occurring. Poor wound healing. We know protein is lacking in the diet. You still need cholesterol, but they have very low levels of cholesterol, lower hemoglobins. We would like them to take that mini nutritional assessment, because in younger persons will say to do a 24, like we've talked about, 24, 48-hour diet recall. We want to see what they're eating for the week and looking at not only with their nutrition, but that ability to cook food, ability to get the food, and maybe they can cook it. So again, that mini nutritional assessment. Cigarette smoking is just what it is. We want people to quit smoking. When we talk about the 5 A's, we want to ask them, do you want to quit? We advise you to quit. We assess a willingness to quit. There's no use talking to somebody about quitting smoking if they're not willing to do it. Assist them to get what they need to quit, and then arrange for follow-up. There again, with health promotion, disease management, there is free access. We know that safety is the leading cause of unintentional injury or death in the older adults in the United States. You have to think, if they have AFib, are they on Coumadin? Are they on aspirin? Are they having cerebral bleeds? Are they breaking hips? So we have to do a full fall risk assessment no matter where they are. Anybody is at risk if they've fallen more than once, if they've had injury requiring medical care, or even if they have difficulty walking and with balance. And we have to just think of the subtle electrolyte changes and how they're eating, how hydrated they are, all those individual little things to make sure that they are not at fall risk, and how to keep coming back and reassessing that on an ongoing basis. This isn't just the original day you meet them. We're going to have a whole chapter on polypharmacy and medication errors, but this is really scary. 12% of the U.S. population is our older adults, and a third use all the prescriptions that are written. Many of these people are on multiple medications that even do the risks even higher. We're going to talk later on in a chapter about true polypharmacy and what it is, that you'll be reading about the Beers criteria medications that really we recommend the elderly not use in this chapter. And I also have the web link out there for you as the stop tool. And they're saying that these prescriptions really are inappropriate at 35 years of age and older. So as they're talking about, it's things like digoxin, Lasix, excuse me, theophylline, NSAID. So you really have to really understand the screening tool of older persons' potentially inappropriate prescriptions, and have a really good understanding of that, because our elderly population may be seeing multiple providers for different issues, and we, as their nurse or case manager or intake or transitional nurse, really need to stay on top of who's prescribing what and recommending what can be stopped. Immunizations are critical. We say annual influenza for anyone just based on your age at 65. Pneumococcals one time for 65 and plus. Anybody needs a tetanus and diphtheria booster. This can be a catch-all. Some places the elder person needed it when they were still actively working, maybe because of their job, and are probably due for a booster. Herpes zoster, we don't want those poor people to get shingles. That is one of the most painful that they can get that there is. We do recommend those important screenings. Again, we're talking about primary, secondary, tertiary care, but we want mental health, depression screenings. Are they abusing alcohol? Looking for elder abuse and neglect. Heart and vascular disease, stroke risk, thyroid diseases. Are they just not moving around because they're hypothyroid? Worry about osteoporosis and that bone demineralization and the increased risk for breaks and fractures and fall. Simple vision, hearing, and screening for safety. Prostate cancer, breast, colorectal. Those are all things that are still should be screened. Now, as far as treatment, that may be a different option, how aggressive they'll be in the treatment, depending on the age of the person. But again, cardiovascular disease is one of the highest causes of death that we have. So just knowing where we're at. Prostate cancer, second most common form, second most common cause of death in the U.S. I see this becoming much younger, and I am hoping that the recommended screenings drop. Again, that USPSTF recommends screening prostate for men over against it once you're 75. So that's what I'm saying. How old are you? Where are you at in your aging cycle? Breast cancer is the same thing. In 2011, we have a lot new cases at the age of 65. We have to look at the prevalence. We know that this cancer increases with age. Colorectal, we don't even get diagnosed till we're 50 for routine screening. So again, who is your person and what is their family history? What are their symptoms? So we will look again and follow those screening recommendations for older adults, and it's done by leveling. Not that you have to remember the level, but knowing that you have that information available to you as we're looking when people want to ask you, well, at my age, should I be screened for that? So again, this chapter has wonderful guidelines that we use to screen the older adult. Have those links available for you. The book does a beautiful job. Polypharmacy is the use multiple medications, and we talk about the stop criteria, reviewing and looking at them all, and we'll talk about that more later. And the biggest thing is the compliance to the drug regime that they're put on, because again, finances, memory, there's multiple issues that will come into play about staying on the right medication.